So
Can we sit down, please?
Should be working. Yeah, it does. All right, so what I would like to talk about today is neuromonitoring in the pediatric cardiac population. Near-infrared spectroscopy, is that an underutilized tool? So I'm a pediatric cardiac anesthesiologist, and I'm basically doing about 90–95% of infants, neonates, children with congenital heart disease, and the rest of that, basically adults with heart disease, and every once in a while some what we call general cases. So these are the disclosures I have to make. And then what are we going to talk about, or what I was planning to talk about today is, well, why should we do intraoperative neuromonitoring at all? What are the reasons? Is it something we should do? If so, why and how, and is it necessary? Does it depend on the particular patient population, or where are we in this regard? Then we want to briefly go over a few modalities of neuromonitoring in the interest of time, and I picked 3 of those, of which I would like to give you some pros and cons and briefly discuss how they're actually working and how they specifically apply to our patient population, that is infants and children with congenital heart disease. Then in the second part of my talk, I would like to give you or provide you some data of a study that we just recently finished, and that looked specifically at the role of near-infrared spectroscopy and in patients, children undergoing cardiac catheterization procedures. And then lastly, what can we hopefully, or what have we hopefully learned from this presentation, and what is our general, general status quo nowadays. So let's start out, why should we do neuromonitoring? So, and given that this is a pediatric conference, just for anyone who is not so totally familiar with, this is essentially our usual setup that every anesthesiologist nowadays has, or should have, absolutely. You have all your vital sign monitoring here, and this is what your anesthesia machine shows you. And there would no question be at all whatsoever that you have, your circulation monitored. You have your EKG, you have your heart rate, and you have your blood pressure, okay? Second, the oxygenation, okay? Nowadays, every patient gets the pulse oximeter. You have your SADs anywhere, in hopefully every one of us here, anywhere higher than 97. And we also know exactly at any moment and given time of an anesthetic, what is your inspiratory O2 fraction, what is our CO2, our laughing gas, and the actual anesthetic. And then how do we ventilate, meaning, how much volume do we essentially get into this patient, what is our CO2, and our peak pressures, and then lastly the temperature, okay? So no one ever doubts that anymore, and if you just take a look here, so these are essentially guidelines and standard parameters that were put into practice 30 years ago in 1986, and there have been a few amendments, but nothing has essentially changed since then. This is a standard of care. If you ever have any trouble or there are issues with the case and that case were to go to court, and the judge would ask you, well, what kind of monitoring did you have? And you would say any of them, these here at least, that wasn't there, you would run into real severe trouble, and you would have a hard time, if at all, to ever get out of that. Now, interestingly, however, and surprisingly, and to some extent alarming, is, well, how do we, or what do we do to monitor our, our major target organ, which obviously is the brain? Is there anything that we are constantly doing? And as I was saying, surprisingly, no. So we monitor all of the other vital parameters, but there's, as of now, no standard parameter, no guideline that tells the anesthesiologist in this particular setting, you have to use this and this and this. And, if you look at these monitors, then if, you either go on a certain threshold or you have a change in baseline to a certain percentage, then this is what you need to do. So then you wonder, well, so, do you just don't care, or what is the current practice? If you think about, there are millions and millions of anesthetics performed every single year, several millions of those actually just for children who undergo anesthesia. What are we doing to do? And I came across an ad that said, where it doesn't make sense, every other parameter indicates good cerebral oxygenation. So we infer if everything else looks fine, well, then we think our brain is doing fine as well. And then it goes on, logic dictates that acceptable blood pressure and pulse oximetry readings correlate with adequate oxygenation in the brain. So is that something, that really holds true? Does it hold true for a certain set of patients, or what is going on? So usually the practice is that we bump up our blood pressure and we hope that we're getting, better perfusion in the brain. That should help. We increase our fraction of inhaled oxygen. That should hopefully help. And then we also, because the vessels in the brain are regulated or respond to our what we call end-tidal CO2, we manage our ventilation strategies and hope if if we have any issues there, we reduce our ventilation, our CO2 goes up, our vessels in the brain should therefore dilate, and the idea is that will essentially improve perfusion. So can we really say that? And if I already bringing up this question, well, probably there are already some doubts about that. Now, why should we particularly, I'm not saying we shouldn't care about adults or anyone who is here, but why should we particularly care about children with congenital heart disease and think about, is that really a great job that we are currently doing? So, and I want to go with you over a few things. Well, what might not be very well known is actually congenital heart disease is the most common birth defect. And depending on where you look, the numbers vary a little bit from 0.7, 0.8, 1%. Others put it to even over 1%. We probably, this 1% is still kind of underestimating the two numbers, because very likely already in the embryonic phase, if there are any severe cardiogenic or cardiac anomalies, many of these fetuses might actually go as missed abortions. So these are only the patients who were live-born and where any congenital heart disease was diagnosed. Now, thanks to a lot of progress that has specifically been done over the last 10, 20 years, and that affects prenatal care, at times even already prenatal interventions in the setting of a cardiac disease, then later on the actual surgical care, the ICU care, nursing care, cardiac care, anesthesia care, all of this together has actually resulted in the fact that we see more and more patients, babies, survive, getting older and older, and meanwhile living into adulthood. And we see that also reflected in the hospital setting, that we actually get a growing number of patients, which we call, so-called congenital patients, who either come for a follow-up because they have, again, issues with their original cardiac disease, or they were repaired and now they show up for something else. But we do know, and they're sometimes, 20, 30, 40 years old, that they had some underlying congenital heart disease at some point. And because of this progress that has been made these years now, and probably including the next 5 years, it has been predicted for the very first time that we actually at this point have more adults than children who are living with congenital heart disease, because there's just, there's more and more people who make it. 30 years ago, your chances to survive, unless you had just a simple atrial septal defect or anything like that, they weren't really great. And that change that we see in more and more adults has also shifted, or should shift our practice from a paradigm that it was originally survival, that was the goal number one, and now it is more quality of life, okay? So if you went back 20, 30 years ago, and you had a patient who had transposition, so basically a switch of the aorta and the pulmonary artery from the right and the left ventricle, there was not a lot that was done, and could be done. And many of these patients, they were just either subjected to palliative care, or the parents, then later on will tell, well, we can give it a try, but, we can't really tell you if your baby actually makes it, and if so, for how long. So, and that was essentially as it was, and parents were like, well, at least we can give, your child, make the best out of it. So nowadays, this is kind of, it's not so much the discussion anymore, well, will my baby or child survive? So usually if you go in big centers where, like, we're doing like 600 or 800 open heart cases and about 1,000 cardiac cath cases a year, the mortality, is anywhere like in the 2, 3, 4% range. So that has really dropped a lot. So the question is not, does it make it anymore? Well, I want my child later on, to go to school. I want my child, to succeed. They should, get a job and. So what can we do? Because the sad thing is that despite this progress, I mean, these kids are still suffering a lot from neurological morbidity. And depending on what source you're looking at, it can be as high as 50%, okay? And with neurological morbidity, I intentionally left that pretty general, okay? So this really includes a big chunk of diagnoses, whether you have immediate issues, like let's say, the baby has developed a stroke, or the infant, or, some new seizure disorder, and then particularly the long-term cognitive dysfunction, which is in general a very hotly debated topic right now in the entire anesthesia world. What overall are we doing with our anesthetic to the brain, and can we actually expect later on the road any neurocognitive dysfunction, whether it may be ADHD, whether it might be issues in, language acquisition, memory deficits, and. So that is definitely one of the main driving factors that we still need to ask ourselves, well, it's fine now, we managed the actual, survival rate, what have we done with it? And in contrast to the adult world, who also suffer from neurological issues, but in the adult world, it's the etiology is presumed to be different. There we think that it's more kind of an embolic nature. In the pediatric world, neurologic morbidity associated with, heart disease and open heart cardiopulmonary bypass requiring surgeries, there the question is more, well, how much do we have a CNS malformation? And interestingly enough, there are several studies that have been done for pure research purposes. If you take a patient who, for example, has hypoplastic left heart syndrome and you subject them to an MRI up front, what you actually see is even before anyone has touched this baby has never had any surgery, was never in an ICU, that you, in many, up to 30 to 50% of cases, you find already white matter injury, almost reminiscent on, preemies, showing that whatever really happens, that, a factor driving brain injury is definitely this changed perfusion already in utero that obviously is very, very hard. Almost, at this point we can't do anything about it. But the bottom line is that many of these babies already start out with essentially a bad baseline, okay? And then on top of that, obviously, we subject them to surgery, cardiopulmonary bypass. Many of them go through what we call a staged procedure, where we know after several months they will again have a bypass requiring procedure. Some of them, they will need to get cooled down to about 18 degrees Celsius. Some of them, they will still, although surgeons try to avoid that, will have to totally arrest the circulation, which there's debate, for how long is that truly safe. And then we give them anesthesia on top of that. So most likely it's a combination of all of that together that in the end then, accounts for this really significant morbidity. So if we want to try to do a little bit better, then the question is not, well, probably we can't just, make everything great again. But the idea is there anything that we could do with all of these small steps that might account for that, to at least figure out what can we do to not even make all the injury and the burden worse? And in order to, find a goal, we have to say, well, the first thing is reliable and accurate neuromonitoring is essential to reduce the incidence of neurological complications, subsequent potential long-term cognitive dysfunction, and to also then improve, hopefully, the quality of life in this particularly very heterogeneous and fragile patient population. So what options do we have there? And in the interest of time and with regard to the significance specifically to this population, I picked EEG monitoring, transcranial Doppler, and then near-infrared spectroscopy. And anyone who already sees this picture, gets already a hunch of, well, that probably might not be the very easiest, okay, to get those electrodes sit there. I mean, this is obviously an awake baby. Anyone who has ever been in a cardiac room knows, there's a lot of manipulation. It's sometimes very tough to get to this patient. They're under this bar. You have this very small head there, and then, the cardiologist puts the echo probe down there, and then they're moving the head around, right? And then on top of that, you have a lot of electrical interference from the Brovie. So, if you're thinking this is an easy setup, then try that in practice, and you very quickly realize, it's not as easy as it might look. Now, there is a lot of literature, specifically in the adult world, but also growing, in the pediatric world, that says, well, what does an anesthetic actually do to our EEG? And so it picks up, the neuronal activity, mainly from the surface of the brain. And surface, it usually does not really go deeper than 4 centimeters in the adult world. And the typical pattern is that if we are awake, so I hope this is what I would see with any one of you at this point, okay, that you have a very high frequency, all right, of small amplitude pattern. And the more and more as you're drifting off, awake, moderate sedation, general anesthesia, deep anesthesia, and at some point actually you get burst suppression. The general pattern, what you see is that you get a slowing, frequency goes down, and the amplitude goes up as you go through all of these stages. And the idea behind that is that with this anesthetic, although still no one really knows for 100% how it really works, but you get more and more synchronization between the various anesthetic neuronal networks, and so that you essentially, since they are no more in sync, rather all firing at different times in space there, you get this more synchronized pattern. The problem, though, however, is that no one at this point still knows, well, how do we use that in the pediatric cardiac setting? I mean, yes, we can put this on, and there is also a debate, should we do a raw EEG or the processed one? The raw is very, very tough to read. You need to have, extra training for this. There are, some companies that advertise the processed one, and that essentially just, throws a number at you, but then the question is, what is the true, neurophysiological correlate? So, and then in the end, well, if you do see any changes, what are we supposed to do? And a very, very limited number of studies, not more than 2 or 3. What they did is they took EEGs, they took patients, and the EEGs were read as entirely normal, and they did pre- and post-procedure MRIs, and the kids, several of them had actually ischemic injury after the procedure, and it was not picked up on the EEG. Conversely, some EEGs were read as that there were some portions of abnormal activity, but the children did entirely normal within the range that they were tested. So the final, answer to that is pretty unclear at this point, okay? So the good thing would be, well, we really monitor what our target organ actually is, and that is neural activity. It can be done at the bedside, and with that I mean, for example, in contrast to an MRI scanner, a PET scanner, a CT. It measures continuous activity. It's non-invasive. The cost is a little bit debatable. It depends on if you have to have an extra electrophysiologist who really reads it, and then it's getting really more expensive. Otherwise, it might be the cheaper option. The good thing also is you do not need any pulse. And why is that important for us? Well, when we are putting a patient on the bypass machine, and usually nowadays You have the roller pumps, and they don't give you any pulsatile flow. Any neuromonitoring modality that relies on any pulsatility will not really work out. For example, if you put a pulse oximeter on someone who is on bypass, and it will not work because you need to have that pulsatility. Okay. So, and then the cons that I was referring to, well, it's very challenging to really get this up in the setting there. In most cases, you might need to have an extra special trained person. Spatial limitations, you can't really get deep enough if you really want to get everything. And then one of the main things, well, you have to have a certain algorithm. So while there's a lot of data in the adult world, you can't just transfer that, what is working for the adult, on the pediatric side. Then number two, you also have several difficulties arising from the fact that your EEG pattern is very, very depending on how old your child is. So an EEG, even an entirely healthy infant neonate, again, looks entirely different than if you have a 2 or 3-year-old or than a 10-year-old. Then on top of that, you add the layer that your anesthetic depth actually, as I showed you, modulates that, and then also you have temperature dependency. And in the adult world, in the pediatric world, in contrast to the adult world, many of these procedures are done under at least moderate, if not profound hypothermia. That means anywhere below like 27 degrees Celsius. Okay, so we can't at this point in time, we don't really know if this is a good modality. Transcranial Doppler, it might look at first sight, it's a little bit easier to put on there, so you either can have like a disc sensor, or if you have an older kid, essentially is identical to an echo probe. And it can also be, this is one of the devices, it is portable. So these are all things that, you might think, okay, well, that works great. The principle is basically similar when you do an echocardiogram and you want a Doppler, what is the flow across the mitral valve or the aortic valve. If you want to Doppler or use this technique for brain monitoring, usually the artery which is mostly used is the medial cerebral artery, and then the pictures that we are getting is basically underflow, this kind of pattern, and then you can calculate a so-called, so you get the velocity of the red blood cells. There are several parameters that you can calculate, and they will then tell you, what overall is going on with the flow. These are just some examples what you would see, like a normal 150 centimeters per second flow in the left middle medial cerebral artery. In a child, for example, that had sickle cell anemia, so you have, a reduced hemoglobin, and so your viscosity is lower, your flow is higher. What you essentially see is the peak velocity here is about like 300 centimeters per second, so a very steep rise, a very steep fall. So this is too fast, essentially. And then this gives you just an example, well, what is happening if you have a very sluggish flow, reduced flow? First of all, your peak flow is, only 40 centimeters as opposed to per second, as opposed to 120, and you also see this very sluggish decline. This is in a patient with Moyamoya disease, which is essentially a disease where you have in the brain, cerebral vessels, a constriction, and then you have the formation of pathological collaterals that, however, don't act and don't behave as the normal ones. And then the flow is basically, the brain tries to direct flow through those collaterals, and therefore through the actual constricted, sometimes also thrombosed vessel, as in this case, with reduced flow, you see these kinds of patterns. So also whenever one is doing transcranial Doppler, it's very important to know that you say, well, high velocity, great, then I have good blood flow. That's actually not the case, because a big parameter is your diameter, okay? So if you restrict your diameter and your resistance goes up, you actually can measure a higher and increased velocity, but overall your cerebral blood flow nevertheless still might be reduced. So how does that look like then for this modality? I mean, would that be something that we would consider in the pediatric cardiac OR, okay? So, well, we monitor blood flow. Again, good points are it's a measurement that runs continuously in real time. Another good value point would be that it also detects emboli. So, for example, emboli are very important, like whenever we are going on bypass and we're putting the cannula on, that, just by putting the cannula in the ascending aorta, or sometimes because everything is so much smaller, the surgeon sutures a graft on the innominate artery to then direct flow immediately into the cerebral vasculature. If there is like any embolic or any particle that goes there, you can pick this up. Similarly, at the end towards the bypass, you want to ensure that you have the heart entirely de-aired, and if that doesn't happen, then sometimes you can also pick up so-called hits, these events. So all of that would speak in favor. But also that is actually, in terms of, putting it on the brain, it's very, very crucial that, this probe that you're putting on there always maintains the exact angle of which you started out with because of this Doppler principle. So if you're kind of just moving off a little bit, you will get, a different pattern. And the question then is what actually has happened now. And then one of the other big disadvantages is that, similar to the EG, we don't really know, because of its unclear role at this point, well, what should we do even if we do see a reduced rate? Is there anything what we can do? TCD was very, very beneficial and effective and taught us a lot. Like, for example, what flow does the bypass machine need to be running at various temperatures so that we can still get a flow that, we think is sufficient. Or it also taught us, for example, that the pressure flow autoregulation is still maintained, at normothermia, but then gets lost when we cool the brain. And this is a feature that basically each of us, as we are here, the brain regulates between a blood pressure from 50 and 150, the flow in your brain. And, once your pressure goes either below or up that, then you have this passive relationship that either your flow drops or your flow increases. So this relationship gets lost, under hypothermia. So there were several good things to learn from that transcranial Doppler, but it really never made it to the point that we could say, okay, is that something that we overall want to do? So then one of the last one is obviously then the near-infrared spectroscopy, and that is a very simple slide that shows you, well, how does it essentially work? There are right now 4 different companies that make commercially available devices, and although there are differences in the architecture and the sensor, how they work, one principle is that you have one light source or one emitter, and then you have on the other side, this is essentially just a sticker that is being put on the skull and the forehead, and you have 2 detectors, and one shallow and one deeper one. And the way it works is that wavelength in the range of about 600 to 1,000 nanometers are essentially emitted, and the further they're spaced apart, the deeper they go in there. And you want to obviously subtract any interference that is caused by absorption from the skin, the subcutaneous tissue, the bone, and anything else. So by measuring this here, this absorption, and then ultimately subtracting what is caused by bone and anything else, this then gives us an idea of the actual tissue oxygenation in the brain. Okay, it's also important to realize that what the device will show you, it's a so-called weighted number. So it is, depending on what device you have, about 70% venous part, 30% arterial part. Capillaries are considered to not contribute to that. But it does essentially give us an idea on the O2 balance, how much do we get into the brain and how much is coming out there. Very briefly, this is the principle, just the Beer-Lambert law, and the idea is, the more and more wavelengths your device emits, the better you can essentially discriminate between reduced hemoglobin, oxygenated hemoglobin, and anything else, melanin, for example, if you have dark-skinned patients. And so what we did is to get to this new elite foresight device that we tested, which at that point was not validated or approved by the FDA. So the company approached us and said, would you be interested in validating this for neonates and peds? And we said, yeah, we can look into that. The idea is you have a better discrimination specifically for dark-skinned patients and in particular for patients who are cyanotic. And this one was obviously for our pediatric cardiac patients. Many of them have original SADs in the 80s, which is considered normal, obviously very interesting. So this is then how this device actually looks like. It just gives you, these two numbers, left hemisphere, right hemisphere, and then there are like some how should I say, suggestions. If you're in the green area, then you're okay, 60 to 90. If your number is too high, that's not good. Why? Because then probably your brain doesn't really extract enough, and then if you're below 50, that's really bad. And these are then the interventions, an algorithm that has been, suggested, and you might say then, well, fine. What is your problem then? I mean, you can measure it. It tells you should do this or this or this. Well, there is a problem, and the problem is that all of these values essentially were obtained in adults who were healthy, and so we can't really say, well, what is really going on in the pediatric world? And so therefore, the good thing are, it monitors the O2 balance. It has in many publications been shown to be a very sensitive marker for hypoperfusion, hypoxia, and ischemia. So what do we do about that? It also, as anyone else does, have cons. So none of these methods that are out there at this point, they are perfect. However, it seems that at least this device shows us the least negative that we have, because it really gives us an idea, well, what is the oxygen balance? That is something that we absolutely have to know. It can be done at the bedside. It's very, very easily applicable. We don't have any other interferences. It is a cheap means to do that. So when we moved along then with our own patient population, this, by the way, gives you idea how, just small the sticker is, and we put one on the left and the right hemisphere. And we asked essentially two questions. In the last 2 or 3 years, there have been 2 studies that have shown that whenever this NIRS technology was applied, and they followed those patients up for 3 or 4 years and then subjected them to learning tests. And it was one particular cardiac disease, hypoplastic left heart syndrome, that they picked. And they found that over time, patients who did poorly with their oxygen tissue saturation, less than 45%, that they performed worse on these learning cognitive tests. And and it also depended on the particular task they were given. So they were not doing globally bad, but they had specific gaps, for example, in 3-dimensional thinking and. So we wanted to further look into that, and therefore tested this new device with the idea, well, can we validate that? Is it really better because it has a different technology compared to the other ones? That was the first aim that we had. And then the second aim was, well, what we were really interested in is, and that gets me back to the first slides, the anesthesiologist thinking, I have my blood pressure, I have my pulse oximeter, I know what my CO2 is, so I think I should be fine. Well, why don't we take, over the course of the actual procedures, capture what our new NIRS device shows us, and see how does it actually correlate with our vital signs. And we usually don't do those NIRS monitoring in these cardiac cath cases because no one thinks it's actually necessary to really do this. So we got IRB approval, and we did our generalized anesthesia as we would always do. This is just the doll here. So we put 2 sensors on left and right. We also put a sensor on the abdomen on the right and the left side, which I will not go into. this gives you an idea. And then we sampled blood from the jugulary vein bulb. So this is a baby that we did. So you see the catheter up here. It's very important that you at least go the absolute minimum above the subclavian vein, because what you want is you want to get the venous drainage from the brain. And this down here is a catheter in the descending aorta. And so we sampled that at various parts throughout the procedure, and then calculated this weighted value that we call or describe as our reference number, and then we did our correlations. And this just gives you one idea on how this actually looks like when we got this data. So in light green is our inspired fraction of IA2, and we usually start at room air. This was a patient, a 4-year-old who had a hypoplastic left heart syndrome, was palliated with a Fontan, so and came for ballooning of the pulmonary arteries. And so we started out, this one here's the ballooning, and then the cardiologist usually asks us to increase our FiO2 up to 100, which you see here. And the blue colors are the NIRS here, a little bit less than 80, which we consider normal. And then as soon as the balloon goes up, okay, you see this significant drop here for the time being that the balloon is up. And once the balloon comes down again, it returns. And these are the SADs that this patient correlate nicely. At the same time also, your CO2 drops as the balloon goes up because there's less blood going through the lung, and so you you ventilate less. And at the same time, your blood pressure also drops a little bit and then comes up because, again, your cardiac output is impaired with at least one balloon up in the pulmonary artery. Now, this looks entirely different. This is a 2-year-old little African-American boy had pulmonary atresia with an intact interventricular septum, and he had only the first stage, what we call the Glenn procedure, at which point we would still expect his SADs to not be compared to the normal population normal. And as you can see, his SADs are a little bit over 83%, and our FiO2 was here, and his NIRS is kind of like fluctuating up and down, and these are essentially, this is just one example over 1.5 hours. So if we then plot that, we kind of see that this was our gold standard, basically calculated from the SADs in the above the jugulary vein bulb and the descending aorta compared to what our device would give us. In an absolutely perfect world, okay, we would kind of expect a line exactly here, so that no matter what our measurements show us here, this is the number that the device would tell us. Well, obviously, this is a perfect world. These were patients, no computer models, plus on fact they're extremely heterogeneous population. And with that, we got a pretty good correlation actually of 0.7 in these kind of samples. Interestingly, after we were done, so this is a preliminary data set, you might want to ask, well, what is this here? And for other reasons, this baby actually got an MRI of the brain after procedures, and we found that he actually had a subdural hematoma and infarction, which from the beginning would have been exclusion criteria. This is the way how we usually, if you do these kinds of studies, how you present them. It's a Blunt-Altman plot, and basically the important things are, this is the bias and the precision of 0.2% plus minus 6%. And if you're not familiar, well, what is a good or what is a bad value? The absolute lowest under ideal situations was about like 3.9% in healthy volunteers. And the way they did was essentially with a mask and had them inhale nitrogen, and volunteers who were awake. So, and to wrap up with this, if we think now, well, our blood pressure correlates with what we measure, our SADs correlate with what we think is going on in the brain, then we would expect that, our numbers should be all up here. Meaning, if we know our FiO2 goes up, then our saturation in the brain should go up. But this is not what we found. Instead, we found an extremely high, variability specifically for the blood pressure. And what does it tell us? Well, first of all, it tells us that the cerebral oximetry, as it's done by the NIRS, it does detect saturation events that we would otherwise not know about if we had just put our standard monitoring on. And it really, I think, it advocates or should make us think about, well, is that something that we should put in more procedures, not even in the pediatric world, but actually also in the adult world. So to wrap up, while there is no lack of monitoring, I only picked 3. I mean, there's essentially 6, 7, or other 8 modalities. It is still not routinely done. But given the larger and growing group of patients who have congenital heart disease and who survive, we should essentially really do our best. Could we combine transcranial Doppler and NIRS together? That might be one option, but the question is, how feasible is this? And then this particular tissue oximeter that we tested that is now commercially available and has been FDA approved, it showed pretty promising performance in this very complex and heterogeneous population. So to, I think, keep in mind is all of this taken together is similar to having standards that are now 30 years old for blood pressure, pulse oximetry, and tidal CO2. It probably should be our goal to come up with a similar guideline and say, what can we do for neuromonitoring? What is the best way to ultimately improve patient outcome?
I have a question. Have you ever tried somatosensory and motor evoked potentials? They're very sensitive to ischemia.
So the motor and somatosensory evoked potentials we routinely do actually in the neuro ORs, okay? Specifically spinal cord procedures, yes. The thing though is that what you're doing there, that would not really work in the cardiac room, okay? So the motor evoked potential, number one, they only work if you don't give the patient paralytic. Okay,
you need to use the
so clearly we need to, give them paralytic. That's one thing. The other thing is if you do somatosensory evoked potentials, depending on where you put that. In many, in the spine room, you usually you can put them on the foot, and the calf, on the leg, or on the hand. And what you obviously want to do is you want to monitor your ascending pathway in the spinal cord. Now the thing is, and you pick them up, in the brain, and you're thinking if you have slowing, reduction of this amplitude, that anywhere along the way you have an issue, right? Well, the problem in the cardiac world is that number one, the cooling that you're doing. If you do arrest the patient, meaning there's absolutely no circulation anymore, you will for sure have some, exactly, because you're measuring here. And number 3, there's extensive literature showing that you want to have an anesthetic that interferes the least possible with your neuromonitoring, okay? Because the anesthetic itself, specifically propofol, already results in a reduction of the amplitude. The problem is many of these anesthetic, like propofol, they are frequently not hemodynamically tolerated by these really cardiac sick kids. So, I mean, I think it's an excellent idea. I think we would just need to, have a more target-specific measurement really at the brain itself rather than in the periphery. Yeah.
And as a general pediatrician, is it only recommended for the patients with certain groups, like who are more predisposed to hemoconcentration, or do you recommend it for all the congenital cyanotic heart disease patients?
I'm sorry, what was the first part of the
I'm just saying that is it for all the cyanotic or acyanotic heart disease patients, or is it for the ones who are more predisposed to hemoconcentration or with a decreased pulmonary flow?
It's cyanotic patients with,
Yeah. So one of the last slide that I showed you is we unfortunately, or there was no pattern that we could say the cyanotics, were not that responsive as the non-cyanotics, which would have been nice. Okay, if we could conclude, well, if a patient shows up with that and that pathology, with that level of oxygen saturation, they will respond like this or they will respond like that. No. So we have another 25 that we need to look at. At this point, we don't know. There's no pattern that we could say this one will respond like that and this one, yeah.
How does mixed venous saturation figure into this equation? Well, measure tissue perfusion and cardiac output.
So the thing is, okay, so mixed venous saturation, it's a term that works well if you have normal cardiac physiology. Okay, you would get that obviously, like from in a true precise world, you would get that from a PA catheter, right? Where you get your mixed venous one. Otherwise, you get central ones, right? So, but even if we neglect that at this point, so for the purpose of the cerebral sets, we wanted to go up here. For the purpose of the somatic ones, which I have not shown here, there we actually, took a mix of the IVC and the SVC, because the problem is, in many cardiac patients, in these ones, if as soon as you have a left to right shunt, whether it's on the atrial or the ventricular level, you can't take this as a surrogate marker anymore, right? So then you are lost with, well, what should we do? And the next thing is, even if you take IVC blood, and I had several conversations with a cardiologist, depending on where they sample that, you have a mixture of hepatic vein blood and IVC blood. And your hepatic vein blood usually has a much, much lower saturation than the rest of it, right? Because a lot of cardiac output goes to the kidneys that don't really extract a lot, but you get this back, and usually you have this mix there. And even if you take the same patient, depending on what kind of stream where you are in your catheter, you can have a real mess up in this mix. Okay, so all of that would work with the normal physiology. You could then even go just in the RA or in the RV, and everything would be fine. But if you have only one ventricle, or if you huge VSD, it doesn't help. So.
Thank you for an excellent presentation and the comments you made on the neurodevelopment condition of these children. Of course, this is the ultimate goal today in congenital heart diseases. I would like to ask you questions. First, have you seen any correlation between pH and lactates with your infrared findings, with your measurements? Have you seen any correlations? So it can work opposite. You see the infrared and you know that you're in an acidotic condition, or you don't have the infrared information, and through a black gas you can summarize that you're in trouble. This is the first question.
So if there weren't so many other issues with these patients, because many of these patients, they are also on Lasix and they're super, super dried out, okay? So when all of that already goes on for quite a while, so what you essentially actually may see is that their pH might not even that much off, okay? But for example, they have a very high PaCO2 but a positive base excess because they have this real significant contractional alkalosis. So I think if one looks at what you're asking, this would probably be more something for acute changes rather than, if you're getting a patient who has been already, even if they are, a few weeks old, their PaO2 is on many instances like 30 or 40 millimeters, okay? So their baseline sets are 70. We sometimes do keep them intentionally on subatmospheric oxygen, so we ventilate them with like 0.18% because of the fear that just there's too much blood going through the lung, and whatever goes through the lung doesn't go into the body, and then their lactate actually goes up. So there are many other things. It would be an interesting question, and obviously we have for all of these patients, because this is how it was done with coaximetry, so we do have the lactate and the PaCO2. But these were also then PaCO2s obviously obtained under anesthesia, right? So in the moment you intubate the patient, the moment you ventilate them, that already affects that too.
I'm only asking on the acute phase because that's the interstitial.
Yeah, yeah.
And my second question is, do you check these patients pre and post operative with neurodevelopment before or after?
Yeah, we would have loved to do that. The thing is, I mean, the ideal, scientific approach would have been to just say, okay, all of these 50 patients, we just get a brain MRI before and afterwards and see also what is going on. Unfortunately, this cost-wise, that would just not been feasible, okay? I mean, if there's no true indication for us to do an MRI, we couldn't just throw the parents the bill, and it would have added, many, many thousands of dollars on top. Yeah, the neurodevelopment assessment is very, very difficult if you have 2 or 3 month olds, okay? Oh yeah, yeah. These are studies that are absolutely ongoing. But yeah, totally. I mean, and that is what I was referring to. This study from George Hoffman in Wisconsin, where they did, the hypoplast. They underwent the first step, the Norwood procedure, and then they followed them for 3 or 4 years. Okay. And probably Laura, who was just telling us about the asthma, for a few months or so, you can imagine what infrastructure you'll need to have, if you want to follow these patients for 4, 5, 6 years. Many of them, they are flown from everywhere in, right? But that would be the absolute way to go. And from these few studies, very limited, we know at least, that whenever that NIRS was really, really low, they did not really do great. But there's this big also, discussion even in the adult world, patients with shoulder surgery were, if they hadn't had a cerebral NIRS sensor, everything else was totally perfect. And actually, his SATs totally dropped, and that was a case report. So I think we just, what we don't know, we are not worried about. And so, as soon as we kind of slowly get an idea and say, well, it's not always, we think our blood pressure is great and our SATs are fine and we can sit back. I think this is just the wrong, it's misleading.
But even after some palliative procedure, there can be some sort of thromboembolic phenomenon, and that can also lead to neurodevelopmental delay.
Yeah, I mean, there are many things, right? I mean, I'm not saying that this is the perfect finding, or for example, if the transcranial Doppler also in adults, right? If you have a big embolic event, for sure. Usually in kids, embolic issues like a stroke or so, they are not due to embolic events. They are more due to hypoxic ischemic events. Yes. Yep. Thank you.